you for joining us in this educational webinar on HPV. My name is Tom Rich. I'm a Cancer Control Strategic Partnership Manager for Your American Cancer Society and the immediate past co-chair of the Michigan Cancer Consortium. According to the CDC, each year over 30,000 people in the United States are affected by HPV-associated cancers. While the vaccine provides safe, effective, and lasting protection against the HPV infections that most commonly cause cancer, vaccination rates for children in Michigan are slow to climb. This webinar will address national and state HPV vaccine initiation and completion rates, give a clinical overview of HPV-related cancers, and share firsthand knowledge about increasing vaccination rates in clinical practice. We are pleased to offer this on-demand learning opportunity with our partners in the cancer and immunization sections at MDHHS. If time permits, there will be a brief question and answer session following the presentations. To start things off, I'd like to thank our expert level speakers for joining us today. Here's a brief introduction of each. Stephanie Sanchez has worked at the Michigan Department of Michigan Department of Health and Human Services, Divisions of Immunization for over 25 years, currently coordinating the state's immunization quality improvement program. Ms. Sanchez is recognized nationally as a subject matter expert in immunization QI strategies with a passion for HPV. She continuously collaborates with several of Michigan's immunization partners with the goal of reducing HPV cancers through increasing timely vaccinations. Dr. Carolyn Johnston is a renowned surgeon and clinician and teacher. She was the principal investigation for a gynecology oncology group, GOG, clinical research trials available at the University of Michigan, and a past board member of the Michigan Cancer Consortium and the American Cancer Society Great Lakes Division. Dr. Johnston is actively involved in training physicians in Ghana and recently won the SGO Humanitarianism and Volunteerism Award. Dr. Marcus DeGraw is a board-certified pediatrician and child abuse pediatrician. He is currently the medical director of the Child Protection Team and medical director of outpatient pediatric subspecialty services at St. John Hospital and Medical Center in Detroit. He practices in both private and academic settings and in both outpatient and inpatient settings as well. He has spoken nationally on ways to increase HPV vaccination in clinical practices. A warm welcome to all of our speakers. Once the presentations are done, we will have several questions for the presenters to address. Stephanie, we'll start with your presentation.
Great, thanks, Tom. HPV cancers are an easily solvable problem with a huge lifetime impact. Ideally, it is as easy as 2 shots. June 8th of 2006 is when the FDA approved the first HPV vaccine in the United States. It's been 14 years, and we are far from reaching the goal of 80% of all 13-year-olds in the United States from being fully vaccinated with HPV. The HPV vaccine has the potential to help prevent more than 31,000 cases of HPV cancers in both men and women each year. That's 90% of all cases. As you can see from these statistics, HPV leads to nearly all cases of cervical and anal cancer, 70% of oropharyngeal, and over 60% of penile cancers. HPV vaccination rates lag behind those of the other preteen vaccines. Nationally, we're at around 80% for Tdap and meningococcal vaccine. but significantly lower for HPV cancer prevention. The HPV virus causes 6 types of cancer in nearly all cases of cervical cancers. Data models show that we could eliminate cervical cancer if we could raise HPV vaccination to 80% by vaccinating both boys and girls on time prior to any possible exposure. The HPV vaccine is a powerful tool for prevention. This slide shows the annual number of several different diagnoses and treatments related to HPV infection. The HPV vaccine helps prevent infection by virus types that cause many of these. Preventing HPV cancers is less expensive than testing for and treating cancer and precancers. HPV vaccination reduces costs associated with abnormal pap tests, office visits, and procedures for cervical cancer prevention. Well child visits that include the HPV vaccine may increase reimbursements, and the cost of the HPV vaccine itself is regularly covered by most insurances in the United States. As well, the Vaccine for Children Entitlement Program does include people up until the age of 19 years. Human papillomavirus are a common family of viruses. HPV types differ in their tendency to infect cutaneous and mucosal or genital epithelium. More than 150 HPV types have been identified, including approximately 40 that infect the genital area. High-risk types, 16 and 18, can cause low-grade as well as high-grade cervical cell abnormalities that are precursors to cancer. The low-risk types of 6 and 11 can cause benign or low-grade cervical cell changes, genital warts, and recurrent respiratory papillomatosis. Drs. DeGraw and Johnston will speak more about these cancers later in the presentation. Hopefully you've heard a lot about HPV vaccination over the 14 years. Healthcare providers, systems, and physicians have multiple priorities, all vying for their attention. It can be hard to decide which health or quality topics to choose to prioritize. There are several reasons to choose to prioritize HPV vaccination. The President's Cancer Panel released a report in 2014 calling underuse of HPV vaccines a serious but correctable threat to progress against cancer. And that remains true despite recent gains in vaccination today. The HPV public health problem can be solved, but it will take a broad range of stakeholders and the communities to create a generation free of HPV cancers. Coalitions and public health partners, as well as physicians and others, are crucial pieces of this solution. This slide shows the National Immunization Survey teen results for 2018. This is for initiation of HPV, that's 1 or more doses, for vaccine coverage for people 13 through 17 years old. Michigan is near the middle of all states with having 72.5% coverage for initiation of the series. Looking at this slide, still continuing with the NIS teen from 2018, this shows the series completion for HPV vaccine. Its coverage levels for people still 13 through 17 years old. Michigan remains near the middle with a 55%. That's far from the 80% goal. As I mentioned, this is the NIS teen survey from 2018. Be on the lookout for the publication of the 2019 NIS teen data, which is launched to be released on August 20th of 2020. Moving from national level data to state specific, for Michigan, this data is as of August of last year, 2019. The slide shows HPV vaccination initiation and completion for both males and females, as well as all of them together at different ages. It starts at the left of the screen, showing the earliest recommended age of 9 and 10 years old. Then the routine general recommended age of 11 and 12. It continues in groups through 26 years of age. Remember, the routine recommendation is that a person will be complete with the HPV vaccine series by the time they're 13. The HEDIS measurement is at 15 years old. Are they complete with the HPV series? So it reinforces starting the conversation and discussion at 9 years of age can increase the acceptance and administration of the HPV vaccine. Dr. DeGraw will speak more on this topic later in the presentation. This screen shows the most recent Michigan Immunization Report Card data for adolescents. Each quarter, the MDHHS, that's the Michigan Department of Health and Human Services, Division of Immunization Staff, generates and releases these reports. And it includes pediatric, adolescent, and adult data that comes from the MICR, as well as some school data. What you see on the screen is the Michigan statewide adolescent data as of June 30th of 2020. This slide is also from the quarterly Michigan Immunization Report Card website. The map reflects the adolescent immunization coverage levels as of June 30th of 2020 by zip code. The darker the color, the higher the coverage level. Any questions about the content of the immunization report cards can be directed to our epidemiologist, Christy Bramer, at the Division of Immunizations. Her email is shown on the screen now. This slide shows HPV data for Michigan from the MICR, that's the Michigan Care Improvement Registry, for 13-year-olds and 17-year-olds at a point-in-time assessment on December 31st of 2019, March 31st of 2020, and June 30th of 2020, showing initiation and completion for those two age cohorts. Prioritizing HPV vaccination isn't just about HPV vaccination. It can measure how well you're taking care of your adolescent population overall. HPV vaccination is part of a platform for proactive long-term wellness care with your preteens and teens, where you can head off other issues such as depression and diabetes. The American Cancer Society does support, encourage, and recommend that all boys and girls from ages 9 through 12 get the HPV vaccine. There are several resources and educational information available at the website listed on the screen you're watching now. Whether you're working at a clinic, a multi-physician practice, or at a system level, data helps drive your quality improvement planning and intervention process. For HPV vaccination, knowing your data means getting the baseline vaccination rates as well as the patient denominators. In Michigan, our Michigan Care Improvement Registry, known as the MICR, is a tool that can help. Since 2019, there are several different immunization quality improvement reports available to most practices or clinics that are using MICR. Calculating your baseline rates of patients who have initiated and completed the HPV vaccine series is critical before beginning any intervention. And remember, adolescent health care quality is measured by HEDIS performance indicators, and it's important not only to you, but also to the payers. This is an example of one of the quality improvement reports that are available for your practice or clinic. This shows practice A with their coverage levels and denominators for their 13-year-old population at a point in time when each of them turned 13. This next slide is the same type of report, but with a different practice. In addition to just being able to show you coverage rates, the MICR quality improvement reports can offer a practice lists of patients for different ages, between 6 months all the way through their 18th birthday, that are due and overdue for vaccines. We can really pinpoint HPV and assist with the efforts to get patients back into the office for visits and to get fully vaccinated to help prevent cancer. HPV cancers are preventable, and prevention starts with us. Each member of the team plays a role on improving vaccination rates, from the receptionists as well as the clinical, non-clinical staff on-site and off-site. We each have the power to reduce the incidence of HPV cancers and precancers among patients in our care. Thank you, and now I move the presentation over.
And thank you for listening to this presentation. Thank you, Tom, for the introduction. I'll be quickly talking about malignant and pre-malignant consequences of the HPV or human papillomavirus infection, or if you want to say why we should actually vaccinate. I have no conflicts to disclose. And I think you should ask yourself throughout this talk, do you want yourself, your family, or anyone that you know to have these diseases or their consequences? As Stephanie mentioned, HPV-associated cancers are about 35 new cases per year, and they're more common in women than in men. If you look at female HPV-associated cancers, cervical cancer is the most common, followed by anal cancer, according to CDC data. And they start really increasing in the age group of 25 to 29 up until the age group of about 60 to 64, at which they plateau. The other thing that you should notice is that the disease does not stop at age 65, which is when most organizations recommend discussing stopping screening for cervix cancer in women who've been well screened. If you look at the males with HPV-associated cancers, head and neck cancers or oropharyngeal cancers are the most common, and anal is far down the list as second. If you look at race and ethnicity, it's actually very similar. Women are teal, males are light blue, across women for white, black, and Hispanic, whereas in men, predominantly white men. HPV is a common sexually transmitted infection in the U.S. It's the most common, in fact. It's a small DNA virus. Many subtypes exist, as Stephanie said, and approximately 40 affect the lower genital tract. They're divided into high and low risk types based on their ability to cause cancer. This slide shows the different low and high risk types, and you should note that HPV-16 is most commonly linked with premalignant lesions and associated with the highest risk of progression to cancer across the diseases. This slide shows the subtype associations with various diseases, and you can see that genital warts are mostly 6 and 11. These are benign, and the rest are all listed are cancer, and you can see that 16 and 18 are consistent across the list. HPV DNA is present in cancers of both the lower genital tract and the head and neck. It's the viral oncogenes, however, that make the viral proteins that are most important. These proteins are what are responsible for the cancer phenotype. And it's not enough to have the HPV, but you have to have that HPV DNA incorporated into the cells in order to get precancer and cancer. Persistent infection with HPV is prerequisite for developing cervical cancer, and we presume for the rest of the HPV-related cancers. Throughout the talk, you'll see that most of the data is from cervix cancer because it's easily examined, we have the most information, it's followed and studied for a longer period of time. HPV infection is extremely common. It's usually transient, it's usually asymptomatic, so you don't know you're passing it on. The transmission is asymptomatic. And if you look at type-specific concordance between partners, it's only 25%. So basically, the HPV that you currently have likely didn't come from your current partner. It's more easily spread from females to males. And I have an interest in Africa, and sub-Saharan Africa has the most different types of pathogenic HPV. If you look at the percentage of cancers, no, I'm sorry, the slide's a mess, from these different sites that are associated with HPV, you see that cervix and anal are 90% roughly, and vulva and oropharyngeal, approximately 70%, vaginal about 75%. Anogenital cancers are typically preceded by pre-invasive disease that's also caused by HPV. But there's usually a very long time period between the pre-cancer and the cancer, so there's time to intervene if you know it's there. Pre-cancers are common, so their treatment is significant. Using cervix cancer and cervix precancer as an example, if you take the risk of progression of precancers overall with cervix disease, it's 1%. But if you take the step immediately prior to cervical cancer or carcinoma in situ or CIS, it's closer to 40%, but that takes many years to happen and requires that it be untreated. So in essence, the precancers are detectable and treatable, so intervention is possible. The next 13 slides show pictures of HPV-related diseases. They're a little bit graphic, so if you prefer to skip them, it's 13 slides. This is cervical HPV, typically asymptomatic, maybe a little vaginal discharge, so you can see easily passed on. This is cervix cancer, and it is not asymptomatic, often have postcoital bleeding or intermenstrual bleeding or foul vaginal discharge. These are vaginal warts. Looks like cancer. They're huge, but the woman is immunosuppressed, but it's not cancer. These are warts, a much different variety. This is precancer of the vulva. Looks like warts, but it's not. It's immediately the step prior to cancer. So it's important to biopsy. It's important to pay attention. This is a vulvar cancer. Looks like a wart. Again, a biopsy is important. This is vaginal HPV. The woman is unlikely to know she has it. This is a vaginal cancer or a vulvar cancer right at the junction. These are anal genital warts. Look very similar to the reddish lesion that the arrow is pointing to. That is the step immediately prior to anal cancer, or AIN3. This is anal cancer. A little bit more obvious, ulcerated, probably symptomatic. These are penile warts, likely symptomatic from simple visuals. This is precancer of the penis, and very likely confused with the warts. If you look at HPV genital prevalence in the U.S., you see it's about 42 to 43% in adults aged 18 to 59. Slightly more common in men. If you look at the high-risk HPV type prevalence in the total population, it's about 23%. Again, slightly more common in men. Non-Hispanic Asian adults have the lowest prevalence, and non-Hispanic Black adults have the highest prevalence. It's common to have HPV. If you're a woman, you're more likely to have had the infection at least once, known or not, by the time we reach the age of 50. 80% of women by that time will have had an HPV infection at least once. In most people, it does not persist. This study looked at the development of HPV DNA positivity in college students, and you can see that in the first 2 years of college, 60% became HPV positive, and if you continued follow-up for 5 years, nearly 80% became positive. So it's rapidly acquired. The longer the high-risk HPV infection persists, the higher the risk of cervix cancer or its precursors. 65% of women with high-risk cervical 16 or 18 HPV infection that lasts longer than 6 months will get cervical dysplasia. There are lots of ways to get HPV, but sexual transmission is the most common. That said, HPV DNA has been found in female virgins, 4% in one study, women who only have sex with women, and children with no evidence of sexual abuse. HPV has also been reported to be transmitted from hands to genitals, or genitals to hands in both sexes and heterosexual couples. And I'll tell you that in Ethiopia, some of the HIV positive women have disease on the hand that they use for personal hygiene, as well as on their vulva. Studies also indicate that HPV has the potential to be transmitted via contaminated medical instruments. General risk factors for acquiring HPV: sex, multiple partners, partners with multiple partners, early onset of sexual activity, lots of sexual activity, digital anal contact, digital vaginal contact, does not have to be penetrative intercourse, oral contact, fomites, immunodeficiencies, smoking, age, and other socioeconomic factors. The mean duration of most cancerous HPV infections is approximately 8 months. The mean duration of the non-oncogenic is approximately 4.8 months. Persistence is important. It's the prerequisite for developing cervical cancer and its precursors. Cervical cancer, most anogenital cancers, and some oropharyngeal or head and neck cancers share many risk factors with those of HPV acquisition that I just listed. That said, there are likely other cofactors, and in cervix we know that the use of oral contraceptives and high parity are also risk factors. Now I'm going to go through a number of the diseases that are HPV related. Cervix cancer is the most common. The ACS suggests that there are approximately 13,000 new cases in 2019 with 4,300 deaths. Hispanic women were disproportionately affected. In the world, cervical cancer ranks as the third leading cause of female cancer deaths, and Africa has the highest incidence, and Oceania, Australia, Micronesia, etc., has the lowest. Cervical precancers are 4 times more common than cervix cancer. They're treatable, they're detectable, they're preventable. Most of these are squamous cancers. The median age is 48. 50% of the women are between 35 and 55, though. This last statement should perhaps startle you or alert you. Greater than 15% of cases are found in women over the age of 65. And you remember that 65 is the magic year when well-screened women are recommended to discuss cessation of pap smear screening. Sarah Dilley looked at the age and cervix cancer occurrence and presented in March 2018 in our meeting. And looking at 2 large cancer databases in this country found that 23% of African American women who were diagnosed with cervix cancer are age greater than 65 versus 20% of non-Hispanic white women. Now, most of these women were in a poorly screened group as well, but it's still significant. And you can see they're disproportionately affected. Moving on to anal cancer, it's uncommon, roughly 8,300 new cases a year. It is increasing in developed regions. Women have higher incidences than men. White women are more likely to get it than black women. Black men are more likely to get it than white men. Anal cancer is similar to cervix cancer with respect to the HPV DNA positivity, 90, 95%, etc. Risk factors are similar to cervix cancer, but I might also add that because there are males involved, also includes men who have sex with men, women with a history of cervix or vulvar cancer, and other immunosuppressed populations. This study in 2019 by Desmook et al. Looked at increasing anal cancer incidence in this country and found that it increases by 2.7% per year. And particularly disturbing, they noted approximately a 5-time higher risk of this cancer in recent-born black men, i.e. born around 1986, as opposed to an older generation born 40 years earlier. There's also an increase in mortality. And the authors note, importantly, that almost all this disease is HPV related, and their studies to improve prevention are urgently needed. I would add that it's therefore almost all preventable with vaccination and with awareness of symptoms to detect early disease. Penile cancer is rare, makes up less than 1% of male cancers, also has a precursor lesion. Approximately 2,000 new cases a year. Most of them are HPV related. Much of the disease occurs in the less developed countries. It accounts for up to 10% of male cancers in some parts of Africa, South America, and Asia, whereas it's relatively uncommon or rare here. Urethral cancers, even rarer, less than 1% of all genitourinary cancers in both men and women. It's more common in men. It's 2 times more common in blacks than in whites. And approximately 1/3 of the men present with metastatic disease at diagnosis. HPV is more common in females because it's more likely to be a squamous cell origin than in males where it's a urothelial cell origin. Vaginal cancer, rare, makes up approximately 2% of gynecologic cancers, approximately 5,000 cases a year. More common in black women than in white women. Diagnosis is rare under the age of 45. And I think one of the biggest takeaways about vaginal cancer is that up to 30% of patients with a primary vaginal cancer have previously had severe dysplasia or carcinoma in situ of the cervix or cervical cancer. So those women need long-term surveillance after treatment. Vulvar cancer, also uncommon, but represents about 4% of gynecologic cancers. Most of them are squamous, and in contrast to most of the rest of these cancers, occur more frequently in the developed countries. Approximately 5,300 cases per year. Two different kinds of vulvar cancer, one that's HPV related and one that is not. So we're talking about the HPV related one. It also has the precancer, the VIN3 associated with it, and that is increasingly occurring in younger women, and vulvar cancer is increasingly occurring by 0.5% per year since the 70s. Oropharyngeal cancer, or cancers that come from the base of the tongue and the tonsil, are HPV related. They're more common in men, as I mentioned before, and as Stephanie mentioned, I think, and non-Hispanics are more likely to have the disease. The incidence is reported to be increasing in men despite the associated decrease in smoking, whereas the non-HPV related cancers are also decreasing because they're related to smoking. Usually associated with HPV, and there's probably a precursor lesion with a long lag period in between. This study in 2020 by Pike et al. Looked at socioeconomic factors affecting outcomes of HPV-associated squamous cell carcinoma of the head and neck, and they used the SEER database. They found that it was positively associated with oropharyngeal, so base of the tongue or tonsillar, primary, male sex, and higher education, and negatively associated with uninsured status, single marital status, and non-white race. And although non-white race and uninsured status are less likely to have the disease, their outcomes are worse. If you look at oral HPV infection, risk factors are probably similar to cervix cancer. In non-HIV infected persons, they are more likely to have had recent oral, anal, or genital contact. If you look at the prevalence of oral HPV infection, it's been reported to be as high as 34% in one study. Oral HPV is detectable in most of the patients who have the cancer. And if you have the oral HPV, that's the high-risk HPV type, there's a 2 to 4 times increased risk for cancer of the head and neck. Cancer of the head and neck that's HPV associated is usually younger men. Their outcomes are better. Their short-term and long-term survival is better. The disease is less likely to recur, and even though they're treated in similar fashion to non-HPV types. And if you doubt we need to prevent HPV or that sex is happening, this slide shows some older but true data from Michigan. 8% of 13-year-olds have had sex. 13.5% of high school seniors have had at least 4 sexual partners. And a third of Michigan high school students have had sex at least once. With sex comes HPV, with HPV comes precancer, and with precancer can come cancer. So it seems to me prevention is a valid idea. Cervix cancer, we've worked it out to some degree. By regular screening, we can detect and then treat precancers. We can also prevent precancers. You can administer the vaccine. You can recommend condoms to reduce HPV infection. You can recommend smoking avoidance and recommend avoiding behaviors such as having sex early or having sex with multiple partners. We know less about the other diseases and their impact by modifying behavior. This study by Drolet et al. Looked at population-level impact and herd effects following the introduction of the HPV vaccine. And they did a systematic review and a meta-analysis, and this included 60 million individuals and up to 8 years of post-vaccination follow-up. What they found was that after 5 to 8 years of vaccination, the prevalence of HPV 16 and 18 significantly decreased in girls and women. Another type, 31, 33, and 45, also high risk, decreased in girls. And anal genital warts decreased in girls, women, boys, and men. And after 5 to 9 years of vaccination, CIN2+, so the precursor to cervix cancer, decreased significantly by 51% among screened girls and 31% among women. So the vaccine works. If you look at HPV-associated head and neck cancers and you look at the partners in vaccination history, long-term sexual partners are less likely to have evidence of concurrent HPV infection at the time of the cancer diagnosis. So some people clearly clear the infection faster than others. Those who are vaccinated are less likely to have HPV found on oral rinses. And if you look at the prevalence of oral HPV infection, high-risk types 16, 18, 6 or 11 relative to vaccination history, as this study by Gillison did, you find 0.1% in those who received the vaccine and 1.6% in those who didn't, who had not been vaccinated. So again, it seems to work. So if I haven't convinced you, I'll ask you this question. Why are we so slow? Rwanda has a 93% HPV vaccination rate, and Australia plans to eradicate cervical cancer through use of the vaccination of boys and girls by 2035. Thank you.
All right, I get the easy job. Easy but not easy, I suppose, after all of that amazing data that should hopefully shock quite a few people into action and hopefully support a lot of people's decision to take action, and hopefully many people can utilize quite a bit of that data in their clinical practice to really help support not only their own decision making, but the decision making that their patients and the parents of their patients can utilize in their practice. I'm a big fan of perspective. Utilizing not just that data, but that data and perspective. I'm going to use that a couple of ways today when talking about providing ways to hopefully increase HPV vaccination rates in our clinical setting. I'm going to give an example of that and take just a tiny bit of risk. I don't think it's controversial, but it's 2020, and give an example of perspective as we're all gearing up for back to school. I have 3 children. We're gearing up. An example of perspective as we're all dealing with coronavirus. Perspective with the American Academy of Pediatrics data that was just published. We have in this country about 60 to 70 deaths from coronavirus of children under the age of 18. Yet every year we have about 100 to 150 deaths from influenza in that same age bracket, and at least 300 to 500 vaccine preventable deaths from pneumonia every single year. And I have parents coming into my office every day worrying about their children's health, and I'm being clear that that's about children. When I talk about vaccines for adolescents, and we're talking about HPV, another example of that type of risk perspective, I'll have parents not even bat an eye about giving their child a tetanus vaccination, not even remotely flinch at giving their child a meningitis vaccination, a meningococcal vaccination, but they may resist or significantly have a problem with giving an HPV vaccination. And the simple risk perspective is that tetanus currently may kill 2 people in the United States on a yearly basis. Meningococcal meningitis may fluctuate quite significantly, but on average about 800 people in the United States on a yearly basis, and HPV will kill about 10,000 people in the United States and roughly 40,000 new cancers every year. And that perspective, that risk perspective, just like that coronavirus risk perspective, when parents ask me, should I have an option to send my 5-year-old to school, what would you do? That risk perspective is extraordinarily helpful at making that decision-making process for parents much more simple. And it's a risk perspective that is very, very useful when a parent who is simply trying to make a quick decision about what to do when they're not quite sure, but they've already said yes to these other 2 vaccines. Very, very simple. And we use it every day in our office with very, very good success. There's other things we'll do in our office every day to help increase our HPV vaccine uptake. One of the biggest things is to bundle our recommendations, to treat all vaccines the same, to talk about all vaccines with the same exact language, and to treat them all equally. That's especially true with the adolescent platform, and this can start, in the adolescent platform, we'll start talking about that platform at the age of 9. And I'll even talk about the adolescent platform really beginning at the 4-year-old visit. I had office visits today with children, including a 4-year-old visit. It's my least favorite visit because that age bracket is very cute. They get a couple of vaccines. They get very upset. They cry. They stamp. They get upset. They don't want to come back. But at least I can tell that 4-year-old child that I don't have any more routine vaccines other than the yearly flus, etc., until at least the age of 9. And those children will remember that every single year. They come back for their well visits, that I promise them, other than their flu vaccines, there will be no more routine vaccines till at least the age of 9. And I have then several years of an opportunity to remind that child and that family, remember, I said nothing again until at least the age of 9. Then when we get to the age of 9, I can remind them, remember, I talked about nothing till the age of 9. And starting at the age of 9, I will start recommending the HPV vaccine. It's approved starting for both boys and girls from the age of 9 forward. And so we'll utilize 9 for the HPV vaccine routinely. And then once we get to the age of 11, when HPV, tetanus, Tdap, and meningococcal vaccines are all recommended equally, we will bundle our recommendations with all 3 equally. So we will not tease them out. We will not recommend 2 as required and 1 as possible. We will not tell people anything about school required. We don't even use those words in our practice, that some are school required and others are not. We recommend them all the same. So when we get to the 11-year-old age bracket, we will simply say something to the effect that now that your child is age 11, he or she needs 3 vaccines to help protect them, and those 3 vaccines are specifically for meningitis, HPV-type cancers, and tetanus. Do you have any questions about those vaccines before I order them? So bundle your recommendations, treat them all the same, use the same language. None of the providers or workers that work in my office have anything to do with the school district. We're not teachers, we're not school board members. We have nothing to do with getting children into school. My job is only to keep them healthy, and so I have nothing to do with school recommendations. I will follow the medical recommendations, and therefore, again, school requirements or getting them into school will not be something that we talk about in our office, and we will bundle them based on the medical recommendations. There's lots of reasons that parents may have a barrier or a missed opportunity to get a vaccine in our office or any other office. That may be simply a lack of education on the parent's part or the provider's part. But one of the biggest missed opportunities is simply that parents were not offered vaccinations. There are several studies that demonstrate this. When children leave an office having not received an HPV vaccination, and we capture those patients afterwards and we ask them why they did not receive the HPV vaccination, the number one answer was because they were not asked to do so, that the provider did not provide a strong recommendation for that patient to get the HPV vaccine. And when we asked that patient's parent then what would have been the strongest reason for them to have gotten that HPV vaccine, the number one answer is if the provider had given a strong recommendation to have done so. In addition to that, if the patient was asked who is the number one source of medical information that you want as your source, I am shocked every time to hear that it is not Oprah, it's not Dr. Oz, it's not the newspaper, it's not the television show, it is their medical provider. And so patients want to hear from you. They want a strong message from you. They don't want a wishy-washy recommendation, nor do they want to hear from you. You could get something today. You could do it now. You might do it in the future. You could come back if you want to. They simply want to hear what you want to have them do today and what they should do today, especially what is recommended for them to do today, and for you to bundle all of those things together. Another opportunity that gets missed is that they perceive the vaccine as optional or unnecessary now, that they can come back at any other time. You can wait. We have plenty of time. Often patients will perceive that their providers discouraged a vaccination rather than giving them a recommendation that they should do it today. Parents will frequently want information about vaccine safety. They may have questions. I'll tell my own patients on a day-to-day basis, if I can't answer your questions today adequately, then I don't want you to do anything today. That's why you come. And if you ask questions and I didn't answer them satisfactorily, then you shouldn't be coming here. And you certainly should keep asking questions until you're satisfied. Sometimes parents don't understand the reason to vaccinate a child for HPV at 11 or 12, and that answer is pretty simple. Not only are the statistics significantly on our side on this discussion, as Dr. Johnson discussed, the percentage of kids who are sexually active at a high school age is higher than anybody would really suspect. However, vaccines always work better at a younger age. There's no doubt about that. Of all types, there's not a single vaccine that doesn't work better the younger we are. They all work better when we use them earlier, and this vaccine is no different. In addition to that, when parents say, my child doesn't need it today, they're not sexually active, they haven't been exposed, my response to that is simple. The response is good. That means I can guarantee you, assuming the vaccine itself forms an adequate immune response, then it will work because we've done it before exposure, plain and simple. We've done it before the child needs it, and that's the point of any vaccine. And so you've proved the point why we should be doing it today, because we've guaranteed we've gotten it before your child needs it, not when they need it. What works with parents then is quite simple. Don't give up before you've even gone in the room. This happens a lot with providers. Providers always have excuses for this vaccine more than any other. Flu is another example for providers giving up before they even go in the room. We've already decided that patients always give us troubles, so we go in and we give a weak spiel and we accept defeat. At our office, we don't. Again, I don't go in knowing that parents are going to challenge me. I go in and offer the shot with the same effort that I give every other vaccine. We'll present it the same way that I do tetanus and meningitis, and again, I give that recommendation starting at the age of 9. Don't give up before you've even gone in. It's not recommended to be treated that way based on any health organization that gives you your guidance, and we shouldn't act that way. Parents do want to hear about prevention of cancer. Those statistics that Dr. Johnson gave should be even more remarkable for all of us, and it does work for parents to hear this. The couple of statistics that I like to give that she mentioned, 2 of them. One, the studies that show us that when we give this vaccine, even when we use it only in a population where even a third of those patients receive the vaccine, we can decrease the acquisition of cancer-causing strains by up to 2/3. 2/3 of that population don't even get the cancer-causing strains, and only 1/3 of them are getting the vaccine. That's remarkable. Just think what we can do if all of them get it. And that data is even more borne out by Australia's data. Australia doesn't just hope to get rid of cancer by 2035. Their data is proving that they will do that by 2035. Less than 2 decades from now, an entire continent will have wiped an entire form of cancer from the surface of that entire continent. When I use those words, when I can tell people that an entire continent will wipe cervical cancer off the map with the usage of a vaccine, that's powerful. And parents want to hear that type of information. And that's not hyperbole. That data is real. That's not them hoping that will happen. That data is real. That is happening because they're doing better than we are. And parents want to hear that. Parents don't just want to hear that we can prevent cancer. Parents then want to hear your provider recommendation. They want to hear that with this vaccine we can prevent cancer, and therefore I want your child to have this. They want to hear that the benefits far outweigh the risks, and they want to hear a strong recommendation. Make sure your office has a consistent message. Make sure all of your office staff is on message. Make sure that you successfully communicate at every point of entry to your office the same message. Make sure that the people that answer your phones and schedule your appointments are saying the same things. If you have somebody answering the phone and scheduling the appointments, telling patients, oh, don't worry about that one, you can get that one later, obviously your success rate will be changed. If you have people checking patients out saying, oh yeah, you can come back to get that second dose whenever you want. You don't have to come back in 6 months. It can be next year. Your vaccination rates may be challenged. Make sure everybody's on the same page and is following the recommendations as they're supposed to. Know your coverage rates. Go to people in your office, go to your providers with data. All providers are getting lots of recommendations every day, lots of quality messages, lots of requirements for how we should improve our practices. But data will allow them to not have excuses. If I can sit down on my data and my providers and say, your HPV vaccination rate is only 39%, there are no excuses that are adequate to tell me why you're not doing better. If I don't have that data, they can give me all kinds of reasons why they're not doing better. That's even more important if I can show them that their partners are doubly effective compared to them. So know your coverage rates, know your data, pull them, and routinely go over them with your providers at each location. Make sure your office and clinical policy is in line with that mission. Immunize at every opportunity. MICR is the most amazing electronic immunization registry in the country. I've said it multiple times. I continue to say it every day, and I go to almost every state in the country to talk vaccines. It is completely true. It's fantastic, and you can pull up vaccine records in seconds, and there's no excuse to pull up vaccine records just at well visits when you can pull them up at all visits. Utilize ADHD medication follow-ups and sore throat visits and sports physicals and every opportunity that we bump into our patients to vaccinate as an opportunity to increase our vaccine rates. Utilize standing orders and counter plans and order plans in your electronic records. Utilize reminders and recall systems in your electronic medical record system. And utilize every advantage you have to prompt your patients and your office staff to get those patients back as often as necessary to increase your rates. Make sure your communication with every staff member and patient is on mission. Make sure that when you talk about vaccines, you have talking points, you have answers for your patients that you can communicate effectively. Use personal examples. I'll utilize frequency. The example for one of my best friends who had received a diagnosis of throat cancer several years ago, less than a week prior to getting married, simply with a sore throat, otherwise perfectly healthy, and a sore throat that led to a diagnosis of HPV positive throat cancer. I'll utilize personal experience with other family members that have had HPV positive end disease, significant disease. I'll frequently promise patients I'll pull up my own children's MICR to prove to them how frequently I'll vaccinate my own children. And I'll state routinely that if I vaccinate my own children, of course I'd recommend vaccines to you. I vaccinated all 3 of my own daughters with HPV vaccine earlier than the 11-year-old time frame. Of course I'd recommend it for you and your child if I'd done it for my own children. Utilize those clear, easy, personal examples on a routine basis. Again, MICR is an amazing standard that the rest of the country should follow. You should be providing this for all of our patients. Even when this does flow with the EMR, I'm an old-fashioned guy. I like to read paper books. I like to read paper newspapers. I like to read a paper MICR, and I always will. I don't want the electronic version. I want a paper version. And I want my patients to have a paper version to show us all where we have opportunities to improve. So provide this to your patients at every opportunity. Check your immunization status as often as you can. Call to remind your families about getting their vaccines if they fall behind. COVID provided us an opportunity to fall behind, and we all have. Our office is no different. We have fallen behind. And we have to get caught back up both on vaccines and well visits. And right now we have office staff dedicated. Simply all they're doing is calling these patients who are behind on well visits and vaccines. One way to get caught back up and get caught back up on our vaccine status, especially for HPV, is you must utilize 9 and 10 as an opportunity to vaccinate for HPV. HEDIS measure to complete your HPV vaccine by the age of 13 You need 2 doses, 6 to 12 months apart, by the age of 13. And if you start at 11, you essentially have 2 well visits to get 2 doses in by the age of 13. If they fall behind on 1 well visit, you've lost. You'll never get to the HEDIS measure if a significant portion of your patients fall behind in those well visits or miss a well visit or miss a vaccination. If you capitalize on using that 9 and 10-year-old well visit opportunities, you now have 4 years and 4 visits to get those 2 doses in, and guaranteed you're going to have a much better route to getting that HEDIS measure completed, without a doubt. Be prepared to answer your patient's questions. Utilize your personal examples, but have canned responses to your patient's examples. We have HPV resources down in the lower right. You can click on these and download for your patients that you can provide to them, and you can have them at the ready for yourself. But be able to answer questions when patients bring that up. I love this data sheet, the questions from the parents, and on that data sheet are some very common examples that your patients will ask you. On that data sheet, preparing for questions include things like, I have a question about vaccine ingredients. What about aluminum? That question is one of my favorites because aluminum, most people don't understand, is the 3rd most common metal found in the Earth's crust. It's in every food that we eat. It's found in breast milk. In fact, if a baby breastfeeds for the entire first year of their life, there's more aluminum in that breast milk in total than the vaccines that they'll get during their entire childhood. Even if you don't eat canned aluminum food, the amount of aluminum you'll eat in your lifetime is more than the vaccines that the aluminum you get in vaccines. And that type of response is a very quick, easy way to respond to a parent's concern. They're intelligent and smart enough to know these words. They're smart enough to know I should be concerned about this word. What about aluminum in a vaccine? But most of them don't have the educational background simply in a specific topic to know that it's also in the food that we eat, etc. That's what we're here for, to be able to answer that type of question and response. I'll use the term adjuvant very commonly. That's also in this response. Aluminum is used specifically as an adjuvant. And I'll ask parents, if you can answer 2 questions from me, then what we're having back and forth is an intelligent discussion where you can, constantly challenge me rather than me just simply answering questions. If you can answer for me what an adjuvant is and what it does, then you're going to challenge me. And parents will look at me and say, I don't have any idea what word you just said. An adjuvant is a chemical we add to vaccines whose job is simply to magnify an immune response at the site that we put the vaccine into the body. Aluminum just happens to be the most common part of adjuvant that we add to vaccines nowadays. And if parents can give me that, or I ask parents, when you talk to your friends at your party tomorrow night and they start spouting off about why they shouldn't do things because of aluminum, if they can explain that to you, then that's somebody who has enough intelligence about vaccines that you should very much listen to them. If they don't know what we just talked about, then you can, kindly blow off what they're talking about. Be able to answer those questions, though, and give them examples. And if you can answer their questions when they have concerns, they're going to have confidence in you and they're more likely to respond to you. And that's important. They need to be able to trust you. They need to be able to understand that they come to you to get those kinds of explanations and those kind of responses. That's all I have in terms of increasing rates for your vaccines in your office for HPV or anything else. Thank you for the time.
Okay. Thank you, Drs. DeGraw and Johnson and Ms. Sanchez. In the interest of time, we'll just I just want to address a couple questions that come to mind. The first is, and I think I'll address this to you, Stephanie, although Dr. DeGraw and Dr. Johnson, you are welcome to respond too. we noticed that Australia has this is within a breath of eliminating cervical cancer, and a lot of the HPV uh, uh, strands have the prevalence has went down. Is there any indicators that um, HPV vaccinations are reducing those HPV-related cancers, specifically in Michigan? Stephanie or anyone?
This is Stephanie. There was a study done in pub or soon to be published, but I can't speak on the data right now as far as the current evidence or indicators. I'm not sure if Dr. DeGraw or Dr. Johnston has information about reducing HPV-related cancers directly related to vaccine.
I don't have anything specific to the state of Michigan. However, every other published data throughout the rest of the world, looking at every other vaccine strain in response to vaccination study, has clearly demonstrated reduction in acquisition of the vaccine strains that are responsible for end organ disease, both precancerous lesions as well as cancer lesions.
Okay, thank you. So many providers
Hey,
participate
Tom.
in.
Tom, just one thing. Sorry, I was trying to share my screen, but that one study I mentioned that looked at over 60 million individuals and by Droulet et al., Canadian group, looked at CIN2 plus, so high-grade dysplasia, the next slide, yep, high-grade dysplasia and cancer. You can see that if in the younger age group, it was significantly decreased by 51%. You catch older women, age 20 to 24, that's not old, but older, who probably have been exposed to HPV prior to their vaccination, the decrease is 31%, but it's still significant. And then I seem to remember there was a study in Michigan showing a decrease in CIN3 back when the state was collecting that data, but I think the state stopped collecting that data, as I recall. Ann Garvin could correct me. Courtney, maybe you can correct me. But I'm pretty sure that, but that's older information from, back when we collected that data in Michigan.
Okay, thank you. So the many providers participate in the Vaccine for Children's program, the VFC program. What is the VFC program doing to increase HPV vaccine uptake? And Stephanie or Dr. DeGraw, please chime in.
Thanks, Tom. So the Vaccine for Children program is a federal entitlement program, and any vaccinator within Michigan, including FQHCs, that vaccinate people under the age of 19 can enroll in that, and that offers the vaccines free at no charge for the patients. So what can be done, or what is being done to increase HPV vaccine through VFC? It's encouragement of enrollment of all vaccinators who are vaccinating people of this age range from 9 and up. In addition to the VFC program here in Michigan, as well as several other states, the quality improvement program that I talked about early in the presentation. In Michigan, we do have staff that go out to all of our VFC providers to give a quality improvement visit, which includes reviewing HPV practices at that office and how they can better vaccinate people who come to them.
Okay, and this is available, this is at no cost, correct?
That is correct. Yep.
Okay, thank you. So there are resources available for you if you want to download those. Those are available at the lower right-hand corner of the screen. We ask that if you have found this presentation helpful, to share this link with your staff and your colleagues. If you have further questions or are looking for additional information, feel free to contact Courtney Cole at the email address here, and Courtney will make sure that you get the information that you request. Finally, I would like to thank again our presenters and you, our guests. Special thanks to our partners at MDHHS for developing and coordinating this webinar. Finally, our sincerest gratitude to Amy Stagg of MPHI for being the architect and engineer of this project. Goodbye, stay safe, stay well. Thank you.